Okay, any stage can occur, and you can see that during hydrodissection nucleus removal. The most common time is during the what you call the cortex removal because of posterior capsule. And all these problems can occur like cystoid macular edema, retinal detachment. As I told you, do not pull out, very important. And if you understand this graphic is very important. When you have PCR, do not have coaxial irrigation aspiration. Coaxial I mean is when you have the irrigation aspiration in the same port. So when you have a PCR, switch over to separate irrigation aspiration. Separate the irrigation aspiration, separate the irrigation for the cutter. And if you have PCR, do not panic and inject viscoelastic, preferably viscoat, because the viscoat would go and plug. As you can see here, this is a patient who had a PCR. You can see a small, PC tear there. I didn't panic, I just removed the nucleus, a hard brown cataract, and injected viscoat through the side port. And once you inject viscoat to the side port, you can see that it stabilizes the anterior chamber. And immediately switch over to the, you can see that I am injecting viscoat that plugs the PC tear, and then immediately create a right side port and go bimanual. Don't use unimanual or coaxial because that is going to hydrate the vitreous and make the PC tear more. And you can see here, this hydro rupture, every time you do a hydrodissection, okay, this is again very, very important. You need to decompress the nucleus and you back into the back. Otherwise, you can have a hydro. Can you see that the capsule is opening up there? 100% this capsule, this rhexis will extend across the equator and then go into the posterior capsule. By the time you put the phaco probe, the entire nucleus will go into the thing. You can see this is a posterior polar cataract. I tried to remove the epinucleus and I had a PC tear. There's a sudden deepening of the posterior chamber. Immediately injected viscoat, whatever viscoelastic you have, immediately put tricot. First, always remove the vitreous first, and you use the tricot because the tricot delineates the vitreous. Even God cannot see the vitreous without the tricot. So dilute the tricot 1:3 and make sure that you don't put too much of tricot because you will lose the red glow as well. And you can see that I use a bimanual technique, remove the vitreous first and then don't be in a hurry to remove the cortex and the epinucleus again. Again, another patient, you can see the PC oval, the PC tear occurring. There is a tear which is going linear. You can see that linear across on the PC. And you can see that this is very difficult to convert this tear into a posterior capsular rhexis. But what is important is when you have a small PC tear, convert that into a posterior capsular rhexis. Again, this happened, you can see here, this is a patient wherein, I'm sorry, the video has not come. Whatever it is, this is a postoperative patient. Again, another patient with the PPC. You can see here, the PPC, there is a huge, it's not actually a tear, it's a pre-existing dehiscence which is there in the posterior capsule. Very typically in PPC, there are two pillars in the posterior capsule. And when you remove the epinucleus, sometimes you can see I do the flax for most of these patients, but this was prior to the flax when you got it. But what is important is stabilize the chamber every time you come out of the eye, whether you have Hyalon or HPMC. HPMC normally we don't use because you don't want the HPMC to mix with the vitreous. Again, very important. See how I'm stabilizing that and injecting viscoat or Hyalon or sodium hyaluronate, which is all Indian companies are also making this without much cost as well. So remove the vitreous. You can see the typical two pillars on the posterior capsule, which is very typical of this thing. When you put a multi-piece lens, make sure that put the multi-piece lens, put the haptic in the bag, and don't leave it haptic in the sulcus. But don't leave it in the sulcus. If you leave it in the sulcus, there can be a long-term decentration and even UGH syndrome. So always capture the optic into the capsular rhexis margin. Can you see that how the capturing occurs? This is an optic capture. The lens gets clogged and the lens will not move a micron. So this is the end point is the ovalization of the capsular rhexis margin. Again, very important for you to understand this ball game. So this again, when you have a mature cataract, look at the fellow eye. If you look, fellow eye has got an AC IOL or a glued IOL or iris claw lens. There's a possibility of a posterior polar cataract in this, okay? Because this same thing would have happened in the other eye as well. So this patient had an AC IOL in the other eye, done elsewhere, and this is a posterior polar cataract. Again, you can see here, I do a femto, unless otherwise the patient cannot afford. But even then, femto is a mature cataract. I did a femto catalyst, and you can see how beautifully the nucleus is. There's so much of intraoperative control is much better. But what is important is once you remove the nucleus, you can see it's a fairly soft nucleus, young patient. You can see that typical, you can see the pigments and the cortex in the anterior capsule. This is not actually a PC tear, it's a PC dehiscence which occurs in these things. Again, going ahead, injecting viscoelastic, create a bimanual technique, inject viscoelastic, come out, and fortunately for me till now there is no vitreous. But I tried to be a little more overzealous. That's what you should not do in a posterior polar cataract. So I tried to remove that cortex. You can see that I tried to remove that cortex on that side, and you can see that I ruptured the PC and ruptured the anterior hyalod, not the PC. Already PC is ruptured. I ruptured the anterior hyalod, and obviously I have to go ahead and do a vitrectomy and put a lens, 3-piece lens in the sulcus and capture it in the bag. So again, these are all the patients optic capture where you can see 2 months, 6 months and 3 years, and all these patients do very well. And again, another patient with the posterior polar cataract, you can see here how it is going on very well without any problem at all with the femto. Again, a patient, you can see here how a posterior polar cataract, again very important for you to understand this ball game, very important. You can see that the two typical lines on the posterior capsule, very difficult to do a posterior capsular axis because these lines are extending from one pole to the one side of the equator to another across the posterior capsule. It's a PC dehiscence, making sure in this case I was not able to, I made sure that the anterior hyalod is very intact, and you can see that anterior hyalod is intact, and went ahead and put a multi-piece lens into the bag and captured that into the sulcus, into the sulcus and captured the optic into the bag as well. Again, another patient with PCR, again you can go either limbal or pars plana. What I do normally is to do a pars plana. Only thing is that anterior segment surgeons, you have a little difficulty in going through the pars plana because you need to put a trocar and cannula, make sure that the eye is firm, put a suture there because it always makes important. Again, femto PCR, we'll show it later when we have time. Again, another patient, the nucleus drop, and we can do an anterior assisted levitation, or you can do go ahead and put a ACIOL in this case because the patient was very old, and put an ACIOL, the patient did very well. You can do a posterior assisted levitation also, just to show you different types of things. The most important message is to prevention of PCR, anticipate PCR, do a bimanual technique, make sure that you remove the vitreous first, and these are all the IOL options which we are going to discuss. Either ACIOL, retroiris fixated lenses, sutured scleral fixation, glued IOL, Yamane technique, and sulcus IOL. All these can be done. The moral of the story is very, very important, is that prevention of PCR, early recognition of PCR, good vitrectomy, bimanual techniques. These are all the important messages I want to give. Preferred practice protocols in PCR. Small PCR convert into PCC. Do not pull out, inject viscoat. Use tricord preservative free, bimanual automated anti-vitrectomy. Don't use your scissors or Vana scissors or sponges. Remove the vitreous first and then remove the cortex and the epinucleus. Appropriate IOL, suture the wounds, very, very important, because when you have a PCR, I always suture the wounds like micro leaks. The incidence of endophthalmitis goes up by about 4 to 5 times. Again, management of PCR is very, very important. Thank you again for all your wonderful patience and attention. And this is again another message